Bene, buonasera a tutti, bentrovati, benvenuti a un nuovo incontro dei webinar del gruppo di studio di chirurgia del polso della Società Italiana di Chirurgia della Mano. Oggi abbiamo il grande piacere di avere ospite un carissimo amico, il dottor Igor Golubev dalla Russia, che ci parlerà delle possibilità artroscopiche di trattamento delle fratture pseudatori di scafoide, e con grande piacere do a tutti il benvenuto e welcome Igor, it's a real pleasure for us to have you here, e soprattutto do il benvenuto al nostro incoming president, il dottor Alberto Lazzarini, che con un saluto ci aiuterà a conoscere il dottor Golubev. Grazie Alberto, benvenuti a tutti.
Vado?
Vai.
Ok, Professor Igor Golubev, Dobro Pajalovec. All my Russian is finished, that's over. On behalf of the Italian Hand Society, welcome and thank you for joining our webinar tonight and sharing your experience with the Italian hand surgery community. I shall briefly introduce you to our guests in Italian, of course, and then I will leave you the stage for your interesting lecture. Allora, vi presento il professor Igor Golubev, direttore della divisione di chirurgia della mano e di microchirurgia dell'Istituto Nazionale Russo di Ortopedia e Traumatologia, Prearov, a Mosca. È anche professore universitario alla Human Friendship University Medical School. La sua attività scientifica e clinica è nota in tutto il campo della chirurgia della mano, della chirurgia ricostruttiva, della microchirurgia e della chirurgia artroscopica, e su questo si concentrerà la sua relazione di questa sera. È membro di numerose società scientifiche, la FESH, la IFSSH, l'IWAS, la ISSH, la Società di Hong Kong di chirurgia della mano, è molto conosciuto nel nostro ambiente scientifico internazionale. Ha partecipato ed organizzato numerosi incontri e corsi nel suo paese ed all'estero, e questa sera ci parlerà della sua esperienza nel trattamento artroscopico delle lesioni traumatiche dello scafoide, sia acute che croniche. Un argomento estremamente interessante, difficile, dal quale tutti quanti abbiamo di che trarre esperienza. So, I will leave you, Professor Golubev, the microphone, and we shall be happy to listen to your talk. Thank you.
Thank you, Alberto. Thank you for introduction, kind introduction. I am opening my screen.
Yep.
First of all, I would like to thanks for Italian Society, Italian friends, Andrea, for invitation, for the possibility to make my presentation, to share our experience with such an experienced people, and maybe you can tell us something important to change something. But anyway, thank you, and it's a pleasure for me and a big honor to tell what we are doing in cases of scaphoid fractures, sometimes and mostly about nonunion. My talk is about arthroscopic assisted treatment of scaphoid fractures and nonunion. How we imagine scaphoid fracture usually now, me also, that it's some kind of young people injury, some kind of active situation when people using some extreme devices like in these pictures. It looks like something like sports injuries and high energy situation. But interesting that it's not very new. It's scaphoid nonunion in the past. It's in South Africa, in some cave, there was found the Australopithecus sediba. You see, 2 million years ago, and it was already scaphoid fracture at that time, and it's quite old problem. And you see, it looks like displaced, and it looks like that it was a nonunion in this situation. That this person was 1 meter in height. It was very small. It looks like not a human, not real human, but it still have the problem with the wrist and scaphoid nonunion. It's really, really long-lasting pathology. What about the scientific situation in I'm checking the number of references about the scaphoid now in PubMed. You see it's 3,242 cases, and quite a lot of publication in this year, 163, and already 18 in this year. What about the arthroscopy and scaphoid fracture? It's not so many, for my opinion, 126, and already 7 in last year. What about the non-union? It's surprisingly less amount of publication. Approximately like 1/3 of all the cases of fracture, and also we see the number of last year and this year already nine papers. What about the arthroscopy? It's 60 articles, 7 in 2020. First publication, which was mentioned on the arthroscopy in treatment on wrist injuries in athletes, it was the papers of Terry Ripple, well-known person who was in the beginning of wrist arthroscopy. It was first mentioned in the arthroscopy in the treatment of scaphoid fracture. What about the scaphoid? To me, it's like one of the most unpredictable type of the fracture of the bone, which was really unpredictable. I would like to share with you such a case. This is the person who coming to me with this kind of treatment of scaphoid fracture. It was just approximately 6 months ago. It's some local hospital in our country. It was treated this way. It was closed fracture. It was treated by KY fixation in such a position of and you see that the doctors decided to make some compression. They put a rubber in order to compress the fragment. You see the bed sore, which has happened in this area. I'm removing everything immediately, but interesting, unfortunately I don't have an x-ray, it's healed completely. Both soft tissue and scaphoid, and it was normal function in half a year, which was really big surprise. What is about my practice about the fractures? In our practice, the fractures non-union rate is approximately 1 to 10. We have vast majority of our cases as non-union. Displaced fractures and non-displaced fractures like 2 to 5. Which is most of the cases is non-displaced. Really now, last 3-4 years, no cases of acute peroneal injury. It's not because it's not happened in our country, because of specific situation in the hospital. I try to scope all displaced fractures and fix scaphoid by screw. I do nothing specific in scaphoid fracture cases. I'd like only to tell you my attitude to this kind of injuries. This is just a typical situation with the scaphoid fracture, which is visible how it looks like in a scope, and it's CT, which is in our situation we do always making CT. And again, the fixation of the fracture. This is what double two waist fracture and distal pole fracture. We put 2 screws in this situation under fluoroscopic control, which is really me don't like it. I don't like to make a scope reduction of scaphoid fracture. I would like to explain why. For me, it's really a question about the influence of arthroscopy for acute fracture cases when we talk about the reduction and fixation. To me, the role of arthroscopy for scaphoid fracture is limited by distraction, which is always required in cases of fracture and in cases of arthroscopy. And also, most of the fractures, especially displaced fractures, which is really required for checking of the position, they are usually increased instability inside the joint. And as soon as we make a destruction, we just additionally influence on the ligament, on the structures which was involved in the injury. It is, for me, opposite situation when we're talking about the non-union. Also, fragment reposition and destruction oppose each other. When we try to make a reposition, to put it in the right place, and the destruction is oppose us. It's for sure it's possible to put a KY to make some compression, but really also the optic by itself influence putting inside the joint is influence to lunate, and you can sometimes change the position of the bone just because of the putting the optic inside. Also, the problem is KY insertion for the screw positioning, which is usually used in destruction position, sometimes complicated and sometimes even impossible. Sorry, I would like also to mention the which is essential in case of acute cases, acute fracture, is to remove the interposed fragment, which is really very useful used by arthroscopy, and checking the ligament condition and quality of reposite control after the fixation. Just to put screw under the fluoroscopic control, and after that to control the situation inside the joint. To me, sometimes it's more useful than to put scope in acute cases. Also, my opinion that the scaphoid is really a strange bone, because it's not sometimes the fracture is happened very late after the injury. This is the situation when we see the swelling of the scaphoid. There was nothing on X-ray, nothing on CT, but the patient was very active and asked for MRI, and we did MRI, and it looks like swelling of the bone, no injury really, but in half a year. We put the cast for him, we are checking everything, but anyway, the fracture and non-union happened in 6 months after the injury. This is, for me, typical situation for scaphoid. Why we saw so many non-union, but not so many displaced fracture? Because displaced fracture is a different story for me. And also some cases of delay union, which is quite typical. This is the case, one of the cases of our surgery. You see the union, the person don't want, it looks like to come into unite, but it's not unite. In some months you see it's going to non-union, and we did bone grafting, scope curl. This is this person, and you see the function in 3 months after their procedure, and it's everything was healing, and sorry, and how it looks on skin, just normal. Now I'm moving to non-union, which is to me more important part of the scaphoid story. Non-union. First mention of treatment of non-union, it was 1998, the publication of Davis Rush, Cheng and Pauling. They proposed the resection of the distal pole with radial styloidectomy, and reported 3 cases with good result, and no degenerative changes in radicarpal joint in 2 years, and a good score afterwards. It was the first publication about this, the arthroscopy for non-union, which is not really for healing but for treatment. First bone grafting publication was Joseph Slade and Thess Dodds. They used the cancelled bone graft to the non-union site, which was introduced through the hole in the proximal pole by biopsy cannula, which was used for insertion of the bone graft in the non-union site. And big revolution for me was made by Clara Won and PC Ho by their work about using the bone grafting in cases of scaphoid nonunion. It was first paper for bone grafting which was used through mid-carpal joint. It was 69 cases with 6 failures. No union was achieved, no union was achieved. The big publication also was in one of the last hand clinics about the arthroscopic management of scaphoid nonunion. I learned from this technique from PC and Clara, and starting to use their methods from 2014 to using the arthroscopy way for management of scaphoid nonunion. Now it was calculated from 2014 till December 2020. It's not all the cases, but which was calculated. It's 134 non-union, most of males, which is typical. We are starting from wet and now moving to trying to do completely dry wave because it's more useful. 21 proximal pole, 22 distal third, and 91 middle third non-union. KY is the majority of our cases. Now we move into the screw technique, but not completely. We have a result of 3 months healing was achieved in 98 from 104 cases, which is 94.2%. DASH score in average of 1 year was in 48 cases, decreased from 20 to 8. Technique is quite typical. This is how it looks like. Always starting from ulnar mid-carpal portal and by scope and putting the working devices from radial mid-carpal portal. We never used the shaver, any burr, for removal of the bad bone, and trying to do as much bone, to remove as much bone as looks like not good, till getting the normal bleeding bone. Putting KY from distal to proximal fragment, leaving the fragment not fixed for the healing. Cancerous bone graft, harvesting from iliac chest. We are always using this area for the harvesting by pieces, not more than 3 millimeters inside. Now we are using the infusion line, which is best way to insertion of the bone graft, because you have unlimited amount of these pieces of infusion line. You cut it in a oblique way and you just screw it in a hole, which is really not damage the soft tissue, not damage the tendon, and it's very easy inserted, and you can have it like 10 all the time, and the nurses just pull it as much as you need it. It's very quick, very useful, really cost nothing for the equipment. And also, it's very beautiful. As soon as you see such a beautiful light from the wrist, you see how this line, like I don't know, Christmas light, sometimes looks like the same. This is typical situation. Just an example. This is non-union. Middle half of the middle part of the scaphoid, how it looks like, KY, and the bone grafting, and healing, and movement. One more case with screw, non-union, bone grafting, screw fixation, and movement. Proximal pole also possible to manage this way. You see proximal pole non-union, how it looks like from scope, fixation by KY, sometimes not easy, and also reposition is not looks like perfect, but even in this situation it's healed and function. But really, union is not a single goal of the treatment. That's for us a big story. Shortening the flexion of the scaphoid leads to dorsal intercalated segment instability. All of us know about it. Extension of entire proximal row and carpal height decreasing. And this is also the problem for scaphoid non-union cases. Humpback by itself leads to DISI, and DISI afterwards leads in years lead to snag and arthritic changes in the wrist. What we know about the Humpback deformity? It consists of two main malformations, of its shortening and angulation. Distal fragment, dorsal displacement in sagittal pay also. Angulation leads to shortening, which is evident. Shortening is malignant for carpus, more malignant. Angulation is benign, no disease in if no shortening. Not all non-union by itself lead to scaphoid deformity. Why disease is a problem for the carpal? Because disease deformity predispose the scaphoid to failure of union, first of all. Second, the persistent disease deformity disturbs the normal kinetics of the wrist by decreasing the height of the carpus, which lead to movement limitation. Third, the abnormal joint contact that results from malalignment will cause arthritic changes. And long-lasting disease leads to dorsal osteophyte-induced impingement, which further restrict the movement. This is why disease is not a good thing for the wrist. How to manage the malalignment of the scaphoid in case of non-union? It's from in the beginning we used the Linscheid technique, and from 2017 we started to use our technique of scaphoid deformity correction. Now it's used more than 43 cases scaphoid deformity. This is the case when we use our technique. Some example. It is some citation of the PC. In the presence of intact scapholunate ligament, extension deformity of the proximal pole of scaphoid is corrected by bending the wrist to realign the extended lunate with the radius to restore the normal radial lunate angle. Radial lunate joint is then temporarily transfixed with percutaneous KY inserted from dorsal distal radius through a small stub wound. This is a typical way to correct the Linscheid maneuver for correction of the position of the carpal bone. But it's not an exact impact on the deformity structures. We have the problem with scaphoid, which is angulated and shortening, but we influence on the abnormal malaligned bone by changing the position of the neighbor. All the correction force in this situation is going through scapholunate ligament, which is often lax and eliminated the effort. Even if it's not lax, it's eliminated the effort because it's will tension. It will correct it in complete tension situation. Normal lunate position doesn't mean full correction of the scaphoid length and shape in this situation. It requires some damage also, radius and lunate cartilage, which is evident as soon as we put the KY inside through the bone. This is an example. This is the youngest case of our non-union. This is 12 years old ice hockey player with such a non-union. How it looks like in a child. it's really not easy to find the real position of the nonunion, which is evidently exists, but we succeed, and you see the resection and Linscheid maneuver for correction of the scaphoid, and you see it looks like the lunate is in the right position, and non-union resection was good enough. Bone grafting, fixation by KYs, and it's healed. But really, its heel was really not good position of the scaphoid. Even being everything like Linscheid, that's we don't like this position of the alignment of scaphoid. And this is a malunion cases, which is also happened. And you see that it's not easy to manage this situation if we try to do something in the malunion of the scaphoid. Also, the scapholunate ligament, which is very, very often damaged in cases of like this situation, in cases of scaphoid non-union. This was a very interesting paper which was published in last year. The colleagues on cadaver model they found that in case of scaphoid injury, elongation of scaphoid on 4 millimeters restore all the normal intercarpal relationship, which is very interesting. All the angles coming in a normal situation when you just elongate the scaphoid. What is our way to correct the Humpback and DISI deformity? Nonunion curettage and fragment mobilization, KY introduced from distal fragment under arthroscopic control with checking the adequate insertion of into the proximal pole. If possible, scope is introduced into the non-union. 18 guide needle is introduced in the maximal light point along the radial border of FCR. Small incision on the same point by mosquito forceps is introduced into the non-union. We open in the forceps branches, elongating the scaphoid, insertion the KY and bone grafting. I'm trying to share with you how it works. You see this light, which is coming when we put the scope inside the deep inside the non-union. And one more time, this is the needle coming from this area inside from the volar part. This is the mosquito forceps, which we use just to put in the same direction like a needle, and we try to open the scaphoid as much as possible. And after that, the preposition KY is put, and we fix this elongated, which is very important to me now, the maximally elongated scaphoid. And how it looks like, and this is the same case. You see big gap, and which is filled by the bone graft. This is was used. We at that time used the metal guide, but now we stopped using, and really plastic is significantly easier, more dangerous for the tissue, and cost less. Typical bone grafting. And this is the case which I show you. You see its heel and the long scaphoid, normal position of the lunate in long term. Also, the screw fixation, it's 3 KYs, one for the screw, bone grafting, screw insertion, removal of 2 KYs. Current technique had no limitation for elongation. We can elongate not in 1 kilometer for sure, but we can elongate quite good. I mean, that's why we are not afraid to put a screw and make it some compression, because we see how it looks. It's next day after surgery. You see, it's not a healing. It looks like how the graft is really compressed. We use the screw, getting quite long scaphoid. And that's today's case, which was done just today. It's a young male without any history of serious trauma. Like previously I told you, for me it's a different story when we have displacement and fracture and non-union. It looks like different situation. This is how his non-union looks like. Also quite typical. We use the manual things for removal of the non-union area. Sorry, just a second. After the complete removal of the non-union, quite big gap, and K-wire insertion. Next step, it's needle from the molar, mosquito, and the opening, elongating the scaphoid. Next, it's K-wire in this elongated position. And how it looks like, also checking the scapholunate ligament in order to understand what is changed after the elongation. This is the gap, this is the area, E3, and you see 3 KYs. Sorry. This is, again, this line filled by bone graft. And first, starting of the grafting. And final situation. We use K-wires for this case for final fixation. There was some technical problem with the X-ray. How it looks like before grafting, I mean the X-ray and elongation, and this is final X-ray. You see, I don't have, for sure we are changed the position of the K-wires, but I don't have this in X-ray. Unfortunately, I'm not waiting for them because there was some technical problem, but anyway, you see how it looks like. It's a today case. What about the overlengthening? It's really a problem. At the beginning, I'm afraid of overlengthening of the scaphoid. This the case. This is the contralateral side, normal side. This is operated side. This is contralateral side. You see, this is scaphoid is a little bit overcorrected, but really, till now, I don't have any cases of some STT joint arthritic or something like that, which is essentially influence on the function. It was 2 millimeters of overlengthening. And in conclusion, I would like to tell my opinion. Arthroscopy role in acute scaphoid fractures is limited by negative traction influence and complicated screw insertion. Arthroscopic management of scaphoid union gives the good range of union, 94% in our series. Level of non-union is not a contraindication for arthroscopic treatment. Linscheid maneuver has some limitation and disadvantages in scaphoid shape and length restoration. Length of scaphoid is possible to correct predictably by affecting the fragments through the additional Boral approach. And some overcorrection of scaphoid is indicated in cases of concomitant scapholunate injury. What can I tell about this? This is some video, some animation, just how it's work. A little bit just to share. Thank you, grazie.
Ok, grazie mille Igor. Se puoi uscire dalla tua condivisione di schermo. Please.
Say in English?
Sì, sorry. Okay, thank you, Igor. Thank you very much, Igor. Great lecture, and we have to thank you also for your effort, because now is almost midnight in Moscow, so it's a big
20 minutes.
2 minutes. I can ask I will tell the participant about my comments and so. Per me è sempre molto stimolante vedere queste presentazioni di questo lavoro che si continua a fare per sviluppare delle tecniche mini-invasive con l'assistenza artroscopica per trattare delle patologie che noi tutti siamo abituati a trattare a cielo aperto. Magari, giusto per rompere il ghiaccio, se vogliamo fare qualche domanda, se c'è qualche domanda da YouTube, Lucian. Forse converrebbe farle prima in inglese, così Igor ascolta, e poi la traduciamo in italiano mentre lui prepara la risposta. Ok? Facciamo così, grazie.
I have a question, Igor. Beautiful presentation. I wanted to ask you, why do you prefer an iliac crest graft instead of a distal radius graft?
We always use iliac crest. For me, first reason, it's usually we can do it by two team. It's shorten the operation. And second, we are decreasing the injury for the area of non-union. We are not influenced on this area. And also, I know the publication and the work about that there's no difference in the quality of the bone, but typically when you are harvested, for me, iliac crest looks like I don't know, more serious. I don't know how to tell it. That's why we prefer to, and we use it in a very small incision, very small. I don't have any problem with. Now it's so easy that I'm doing scope and some person take a graft, and I'm just turning, and I have already like this 10 pieces of the line full of the graft, which is very make it very fast.
Okay, thank you very much.
I saw the question from Ricardo about the KY or screw.
Yeah.
I think that the screw generally is better, but sometimes it's not easy to insert because we are not taking off the destruction, and sometimes it's not easy to put. If we have good KY, we put a screw. A young active person also screw, but if it's I'm not sure that some of the KY is good for putting screw. We are leaving the KY. And also the reason when very small proximal fragment, when it's really not easy to put a screw, usually we are always used it from distal to proximal. I never use it from proximal to distal because it's destruction. It's not possible to put it from this direction.
Thanks.
The size of the K-web, the size is quite small.
Yeah, we use 1.2 millimeter.
1.2? Look like less, okay.
But always
Smaller.
3.
Good. I remember that Jeff Ecker used the key wire temporarily, just for 1 month, and then decided after 1 month to use the amber screw through the key wires.
Okay. We are making CT in 6 weeks. If it's okay, we remove the KY.
Okay.
From 6-7 weeks, it's time to make CT. We're always checking the CT, and we're trying to make CT after the procedure. We have such an opportunity. Next day we make CT, checking everything. Maybe sometimes it's some pieces, or if it's possible to it's happened 2 times. Some pieces of bone we are always checking by CT, not X-ray, not give you complete information about the situation inside.
But your keyword are under the skin? Or?
Yeah, under. Yeah, we are cutting under the skin, yeah.
Okay.
And usually, how long does it take to get healing? 6 weeks?
From 6 to
100%?
8 weeks.
6 to 8?
No, not 100. 8 weeks. We never wait more than 8 weeks, because it's for me it's mean that you need to do something, or it's a failure. I mean, in this situation, but it's important to really to put the graft really put it in the pressure. It's like you see it's just very compressed one.
Mm-hmm. Okay, but
it's quite a lot amount of bone. It's really, sometimes you are really surprised how much bone it's possible to put in such a small bone.
It's more than four pieces of infusion line. It's more because in the picture.
Like, it's usual for me today. It was 12 line.
Okay.
It's nurses ask what's I doing. What's happened? Where do you put such? But it's a big gap. It looks like on X-ray that it's small, but really when you check it, it's not like the size of this area is quite big,
mm-hmm.
and it's really elongate, because it's really when we started to move it from the Linscheid technique to our technique, it's increased twice approximately. It's really amount of bone. You need more and more bone. But it's really works better. The healing. What is interesting that you are getting more graft, but you have more better result. I mean, regarding the healing union.
Okay.
Which is also interesting for me.
Mm. And Alberto Lazzarini is asking if you work also in radiocarpal joint, or you simply work in midcarpal?
Usually not. If there is no some indication for radiocarpal, usually it's not necessary. Usually we are not going in radiocarpal.
Okay.
Typically not.
Any problem in those very long elongation, because you left some part of the scaphoid without any cartilage coverage? So
it's also interesting question. We are not checking. There is no cases when we need to make a second scope in order to see what's happened. But I have case when it was case when we remove the Hansberger technique, when we remove the proximal scaphoid and put the medial femoral condyle, and it's not healed, and it was non-union, and I scoped him, and looks like there was zero cartilage in mid-carpal joint, because there was no cartilage on the other side of this bone. This is cartilage only for the radius area, I mean. But it looks like there was something inside, and I put a graft here, and it's united. It was interesting.
Yeah,
story.
sure.
Yeah. But there are any limitations for the technique? Are there any cases of non-union?
Yeah, for sure. We are not 100% succeed. There was also some cases. There was case when I do the technique twice, and looks like everything was okay, but it's really finished by damage. But it was not our technique. It was just put in the graft. It was Linscheid, and it was finishing by really injury of scapholunate ligament. I mean, it looks like big gap, and I do focal fusion afterwards because it's not united.
Okay, and another extra detail about your technique. So, your technique of elongation and aims to correct the DISI by acting only on the scaphoid. So
Only scaphoid.
you're not making any maneuver over the lunate.
No, it's not necessary for me, no, because you are making everything in distraction. Usually in distraction, lunate is more or less in the normal position. And also, usually, you change the position of the proximal pole. When you put in the mosquito, you see that the proximal pole is going to lunate, not distal pole, which is interesting. It looks like it's more mobile. And it's you are changing the position of the proximal pole, and afterward put in the KY and usually, as I showed.
But don't you think that in some very old cases of non-union, there is a retraction of the capsule on the volar side?
Yeah, it's really. Yeah, I agree completely. Now, I'm trying, today's case, I'm trying to remove as much bonus to make the fragment really mobile. You need to remove sometimes some part of capsule, especially, which is not easy, you know it, that to remove the dorsal part and to remove this osteophytes from the distal fragment, which is dorsal, which is really not easy to do. And but it's important to remove them. As soon as you do it, it's usually you see put in the mosquito that you are. It looks like the mobility of the fragment show you that you are on the right way. If it's quite mobile, even if it's long-lasting pathology, it's make you sure that you will succeed. For me, if it's really mobile, if it's not stiff, you need to mobilize it more. Yeah. This is for me different story about fracture and non-union, because your distraction is help you because you need to mobilize the fragment, really mobilize them. Yeah. And opposite situation that's the role of arthroscopy is really different for me.
Yes,
that's what I mentioned.
Another little question, but it's very important for differentiating the non-union from the neck deformity. You perform the arthroscopy, so you can visualize everything beside the joint. In how many cases you decided to change your direction of surgery? I mean, from the from non-union.
I understand. I understand. We are 100%. We have CT before the procedure. That means that big amount of those cases we already understand that there is no idea for us to do the get into union way. We are doing proximal row corpectomy or something like. It's like 2 cases. I think it was 2 cases when we changed the surgery type during the operation. It's not so many, really quite rare, because of also we're trying to put the indication before.
So more or less 2%, 1% of
your something like that.
Okay. So arthroscopy is important.
Yeah, it's for sure, no doubt.
So another technical detail, when I do this fixation, especially in those proximal pores, I found that when the DISI is the scaphoid, the lunate is in DISI, it's more easy to work in the mid-carpal joint. Of course, when you reduce the lunate, the mid-carpal joint is narrower and smaller.
Yeah, I agree.
Do you have you got any tricks to suggest to prevent this problem?
No, for me, when we doing the Linscheid maneuver, you really sometimes need to use the other way, because the entrance is changed. I mean, inside the joint, you are changing the situation. We have different stories. Sometimes when you put in the KY and it's exactly coming to the right way to the proximal fragment, when you elongate it, then afterward the KY is not going. It's going somewhere outside the proximal fragment. Sometimes its situation change so much that it's really and I'm not afraid of it. I understand that it's mean that it's really required elongation. We are really changed the position of the scaphoid.
Okay. Okay.
I have a technical question also. When you elongate the scaphoid and you have a big gap, okay, how do you avoid passing through of the graft into the radiocarpal joint?
Usually, I don't do nothing. Really, I do nothing. But we are checking the CT. I told you, in vast majority of cases, we make CT next day, in order to see if there is something we can just make a second surgery. But it's really, sometimes we have some pieces in carpal, but never in radiocarpal. I don't know why. But it's not coming in radiocarpal joint, because maybe make a distraction your attention so much to the ligament that it's becoming, there is no space.
Okay.
And taking off the distraction, it's like it's closed and you no area to go now. It's like door. When you close the door, you can't go. You need to open the door, and but it's locked in this situation.
Okay.
Thank you.
Thank you, Igor. Really appreciate your discussion. And are there any questions from the YouTube chat? Matteo, have you seen him? C'è qualche commento? Augusto?
Anche in italiano, eh?
Al momento no. Al
No.
momento no.
Sì, ormai lui ha parlato un'ora, parla già italiano. Igor, you already speak Italian, eh? Ok.
Only il corso per favore. No?
Ecco, sì. Ok, se Augusto vuole fare...
un caffè. Caffè.
Augusto o Alberto, volete fare un commento, delle parole di chiusura? Ci apprestiamo a chiudere, direi. Bene. Augusto, vuoi fare...
Andrea, direi che potresti chiudere tu adesso. Dai.
Chiudo io.
In italiano possiamo fare tutti, in inglese sei molto più fluente.
No.
O
Okay.
il vicepresidente.
Nostro vicepresidente.
Vuole dirci qualcosa? Volete? Volentieri. Anzi, approfitterei per fargli un'ultima domanda, se possibile.
Certo.
I have one last question for you. Since, as you said, you can work in extraction, and with the kind of graft that you use, you cannot do a lot of compression with the screw. So, what advantages do you have using a screw compared with key wires?
We can start movement earlier, because it's we don't have any pieces of which is disturbance of tissue, which is everything is inside the bone. Also, advantage is that you not need second surgery, because to remove the KY you also need some small incision or something like that, and that's it. I think so.
Okay, but you're not afraid of having a mobilization of the screw with such a fragile graft?
But it's no, we are not afraid of it, because it's fixed to fragment, and it's really it's I don't know. There is a lot of publication that this kind of fragmented bone graft is significantly better than the piece one. I think you know it. Comparing different kind of graft, it was found that the cancellous pieces of cancelled bone graft is the best way for getting union. For me, it's quite easy to understand, because all the active ferments is going from this graft outside. We are never used the liquid, and it's just harvesting, and it's pieces of really good bone. The vascularization of this bone is going significantly faster, because there is nothing. When you get in the piece of bone, evidently the central part is not get the vascularization. It's coming to it's a death bone. You need to. It's different way, and when you are putting this small graft, it's significantly better. We are not thinking that this is bad graft because of it looks like soft. It's good graft, and it's coming solid quite fast.
Okay.
Thank you. That's very interesting because it goes against
We have
learned in the past.
We have some experience which is not published. We are putting the pieces of bone inside the knee of the cancellous bone graft to the knee of the rabbit. And it sometimes heal in each other. There was Lindbergh experiments with the tendon. They put a tendon, put it in the knee, and it's healed just without vascularity. And bone graft also heal inside the liquid. And it's also important that the synovial liquid is contact with the graft, which is not typical to the other area. It's quite rare in our practice. I mean, in trauma surgery, orthopedic surgery practice, that the liquid is contacted with the graft, synovial liquid, which is usually they are not in a contact. And this liquid coming inside the graft, for me, it's also an important thing.
That's interesting. Thank you very much. Everything was fine. And thank you for taking this time with us.
Thank you. Thank you. It's a pleasure.
Where you are, but we're very happy to have listened to your talk. And maybe we have learned something that we can try to do.
Thank you. Thank you. Thank you.
In the future. Thank you. Andrea?
Yes, I want to join you, Alberto, and all the team, this study group, to thank you from your big effort of the lecture so late at night, and very happy of your teachings, and I hope you give something very significant to spread the ideas of the new approach, especially your last comment on the biology of respect of the biology doing this approach, which is I think it's the leading approach that join every procedure we do in hand surgery. Compared to the general orthopedic surgery, hand surgery is more respectful of the biology, starting from microsurgery, ending up in arthroscopy, which is the latest advancement of the microsurgical approach that we all adopt. And thank you, Igor. Thank you everyone that joined us tonight. Grazie al nostro gruppo di studio, grazie ad Alberto Lazzarini per la sua presenza. Ci lasciamo salutandoci in vista del prossimo appuntamento tra 15 giorni, in cui Sandra Fanner ci parlerà di nuovi emozionanti traguardi nella chirurgia del polso. Thank you, Igor. Hope you to see you soon. Hopefully in St. Petersburg when we met last time, but it was many years ago, unfortunately. And bye. Thank you. Good night. Grazie a tutti. Thank you.
Thank you.
Grazie, Igor.
Grazie a tutti.
Ciao.
Ciao.